Good morning, everyone. Welcome. Happy Wednesday. I'm so excited to be here, and we're going to get started right away. I'm very excited to present with Kids Mental Health Pierce County and Mary Bridge Children's Building Strong Foundations, Rethinking Mental Health for Boys and Young Men with one of my very favorites, Dr. Lucas McIntyre. Welcome. I'm going to ask for a little help from a colleague, Ashley or Gina, if you could let folks in here as we have a meeting room. It won't let folks in. So welcome everyone. Here today with Dr. Lucas McIntyre, who is a child and adolescent and adult psychiatrist who is the medical director of MultiCare's Adolescent Intensive Outpatient Program, which is now here in Pierce County in Lakewood. He's a member of the Pierce County Behavioral Health Advisory Board, has experience working with boys and men in outpatient, inpatient, and emergency settings, including 3 years at the Seattle VA. He was awarded the Star Community Partner Award from Tacoma Public Schools for his educational series for school counselors, now in its 5th year. Dr. McIntyre has provided consultation to local school districts on how to revise their suicide response protocols and has co-authored research on school mental health with collaborations at UW-Tacoma. He was the keynote speaker for our Kids Mental Health Pierce County's 2024 School Mental Health Summit and will be moderating a panel on adolescent mental health at Pierce County's first Suicide Prevention Summit in September. I have chatted with Dr. McIntyre. He has lots of information, so we believe that questions will be answered throughout, but if you have questions, go ahead and drop them in the chat or the question and answer, and if they're not answered throughout the presentation, he'll either try to answer them at the end or he will follow up with myself and we will get them answered. So I'm very excited to have everyone here, and I'm going to turn it over to Dr. McIntyre.
All right. Thank you, Vanessa. Really appreciate it. And I just want to say a big thank you to you and Ashley at Kids Mental Health Pierce County for thinking of this topic in recognition of Men's Health Month and for asking me to do a presentation. So thank you very much. I'm going to go ahead and share my screen. And as Vanessa mentioned, I have a lot of content that I am looking forward to sharing. And I may not have time for questions throughout, but I will be very happy to follow up with questions later. I am going to change which of my screens is being shared. There we go. Okay. So moving on, so topics today that we'll be talking about include suicide, unique factors affecting the mental health of boys and men, depression, some innovative behavioral health approaches, and resources. And my goal for everybody who is attending this presentation is that by the end of this hour, you will have at least one immediately actionable thing that you can do to support the mental health of men in your community. I also want all of this to be data and evidence driven. And when I talk about something that potentially you can take action on, there's going to be this little take action logo at the top. So getting right into it, I want us to think about suicide prevention and different approaches that we can be taking in regards to that. Just to set the stage and to talk about some data behind this, in 2024, 48,824 people in the US died by suicide. Of those, 80% were male. So as we see here, according to the CDC, the suicide rate among males in 2024 was 4 times that of females. And this is a rate that has been persistent over time. As we see here, since 2000, the rate of suicide has increased for both genders in approximately that same ratio of 4 times the rate for men compared to women. But the rate has been increasing over time, which is concerning. And so one way to think about this is to think about the different demographics that may be affected by suicide. Here's some information from the American Institute for Boys and Men. I highly recommend this website. They collect all their data from the CDC, and we're looking at the same data sets that I was looking at for this presentation. And as we see here, when we look at the age-adjusted suicide rate per 100,000 people, American Indian or Alaskan Natives have the highest rate, particularly among men. The second highest is among white men, and then followed by Black, Hispanic, and Asian, Hawaiian Natives, and Pacific Islanders. Now, there's a couple of caveats here to this information, though. Due to the large population size of white men actually constitute 70% of the total suicides in the United States. However, this is also just a slice in time. So we also need to look at how these rates are changing over time. So American Indian, Alaska Native, and white have consistently always been the highest rates for decades. Also concerning is that we have also seen recently increases in the rates among Black men and Hispanic men. Since about 2020, the rate for Black men has increased by about 25%, and the rate for Hispanic men has increased by 10%. Another thing that I want to point out about this graph is that it clumps together people of all Asian ethnicities, Hawaiian Natives, and Pacific Islanders together as though they're a monolithic block, which they are not. I trained in Hawaii for 2 years, and so I'm always looking at how can that information be pulled out. And so, for example, while this suggests that the overall rate among all Asian ethnicities is 10%, or not 10%, 10 per 100,000, if you were to look at just Native Hawaiians and Pacific Islanders, their rate is actually 50% higher than that. Their rate is somewhere 15 to 7 per 100,000. So just some caveats to this information. It's also important for us to think about rates of suicide in terms of age. As we see here, there's a increase in suicide attempts, or not suicide attempts, suicide deaths up until age 64, a little decrease from 65 to 74, and then a drastic increase after 75. It's a little unfortunate that this data doesn't also separate out men who are over the age of 85, not just 75, because when men are over the age of 85, the rate actually increases even more to 51 per 100,000, which is actually 13 times the rate of similarly aged women. And while this data suggests that nationwide, it is older men that are dying by suicide, we are also seeing increased rates among young men, and actually the most increased rates since 2010. And so as we see here with data being tracked since 1970, there was a peak in the 90s of overall suicide rate for young men and women age 15 to 24. And then there was a dip, and then since around 2005, 2010, there has been an increase in both genders. And again, while men are dying by suicide at a rate of 4 times that of women, it is also notable that the rate has also increased for women as well. So why might that be? Why are we seeing this increase in suicide among men since about 2010? And I will be honest, I don't have all the answers. There are some hypotheses out there. There are some correlates, though I have the sense that we don't have the full picture. But some things that may be impacting that. So for example, 70% of young men will avoid seeking mental health altogether. This may be in part due to what people consider traditional masculine norms, this goal for self-reliance, this idea of to be strong is to have to do things on your own. Any sort of help seeking is seen as weakness, which could potentially be a major barrier to treatment. Also, men's health issues can frequently go undiagnosed or misdiagnosed, which are things that I will be talking about later. And so many will suffer alone. Another thing is the rise of social media and isolation that comes with that, as well as comparison. There is a lot of misinformation in social spaces. There is particularly a lot of information about mental health, a lot of misinformation about masculinity and things like that, that can be compounding these issues that boys and men are facing. There's this, you get fed into an algorithm, you look up something maybe related to depression, suicide, it feeds you the same thing over and over again. And before you know it, that's essentially what your feed is consisting of. There are also issues with cyberbullying as well, and driving people to use substance use, which we know can also be associated with increased rates of suicide. Another issue is looking at our overall economic environment. Economic stress is continuing to increase for everybody. There's crises in terms of housing cost, student debt, the decreasing return on the rates of investment for higher education, significant financial loss, significant issues within blue collar and manual labor occupations, decreased support for technical school training and things like that. And oftentimes what we see is that working class men are disproportionately affected by these economic challenges. And so here's my first take action slide. So some things that we could do to reconsider our approach to boys and men. So as policymakers, we could think of initiatives to increase men working in mental health, as there are not many men working in mental health. For institutional leaders, could consider some training in male-specific presentations, which you're in luck. I will be talking about that later in terms of male-specific presentations of depression that may go missed. And then as individual clinicians, or honestly, even as somebody who just has a boy or man in your life that you care about, some things that can help you with that interaction, right? Oftentimes in therapy spaces, we sit across from the people that we're working with, and they've actually done research on this where men actually respond better by side interactions, right? I think oftentimes that's why you see men engaging in activities where it's like they're out fishing or they're out hiking, or they're doing these things where it's not directly opposed to each other. And on that note, doing something active, right? Doing walking therapy, getting out. Men often respond better to humor, just straight talk, not using all the therapy speech and all of that. Men often want to just fix the problem, right? And I think that is okay in a lot of ways, right? I am all for, sitting in the gray of things, but oftentimes they can respond much better to just goal-oriented and problem-solving focus. At the same time, it can also help we can help men express their internal world better. Sometimes many men have what's called alexithymia, where they lack the words to express their emotions. And so oftentimes that's something that as mental health professionals we can bring. Another way to think of this is redefining mental health as mental fitness, right? This idea that instead of taking a deficits approach to mental health, like, oh, you have this diagnosis, you have this pathology, you have something wrong with you, and that we need to fix it. Let's say, okay, there are things that you want to achieve in life. these mental health concerns are getting in the way of that. How do we get you more mentally fit so that you can achieve the things that you want to achieve in life? And I think with that is working towards reorienting what masculine norms really are. This idea of having to not express your emotions, have to do things by yourself, while in some settings can be very helpful, like many things taken too far can be very damaging, right? And reorienting to this idea of, if if a boy or man really wants to achieve things, if he wants to be there for his family and his friends, oftentimes the best way to do that is to help himself first. And helping himself really helps others. I cannot tell you how many men that I've worked with and boys that they don't want to be a burden, right? And they want to be there for other people. And oftentimes I'm like, well, working with me is going to help you help others really well. Another thing that we can look at, right, is social media usage, the preponderance of loneliness, particularly among young men now, as well as talking about the economic stresses that they are facing that are very real for everybody. Another way to rethink suicide prevention is to think about it by industry and occupation, right? Many of us are aware of a variety of demographic risk factors regarding suicide, right? We understand that veterans, active military, older men, gun owners have higher rates of suicide compared to others. But I think another way for us to think about suicide prevention is to look at the rates by industry. So for example, taking an even broader view initially, if we look at the suicide rates for men with bachelor's degree and without bachelor's degree, we see that there is a significantly higher rate, more than double the rate of deaths by suicide for men with no bachelor's degree versus men with bachelor's degrees. And this has only increased, the difference between them has only increased since 2000. And so according to the CDC, there are occupations that have rates of suicide that are even higher than even the already elevated male baseline. So for example, there are very high rates of suicide in mining, quarrying, construction services. These are, hard physical labor industries, agriculture, and as well as transportation warehousing. I will also point out that even among transportation warehousing, the rate is also elevated for females, actually roughly twice the baseline as well. And so one of the things that we can think about is how do we reach out and intervene in these industries where the suicide rate is even more disproportionately increased. And so there are some good organizations out there doing this very specific work. And this is just one example, Hard Hat Courage, which is addressing the crisis of suicide in construction. So another slide of action that you can take. So as policymakers, we could look at what are the risks in our local industries, right? The data that I shared was nationwide. Oftentimes there are very specific local industries that are seeing a much higher rate of suicide. Also, there needs to be more known about this and why, these specific industries have increased rates. So supporting research that looks into that. As institutional leaders, we could look at, are there opportunities for partnering with industry-specific prevention groups or specific companies or organizations in these fields? And then I think as clinicians, we often, we take a social history, we understand, the importance of the big picture, looking at somebody as a whole person, but maybe spending a little bit extra time on, their specific occupation and the stressors that come with that. Another way for us to rethink suicide prevention is to look at means restriction. And so what do I mean by that? So what are the means by which somebody uses to die by suicide? And as I was training as a psychiatrist, uh, these were the things that were often brought up. We understand that guns are the most lethal form of means of suicide, and yet we would also talk about securing pills, securing any sharps, knives, blades that somebody could use to hurt themselves, maybe chemicals under the sink they may try to overdose on. um, but oftentimes there was one other means that was not talked about unless we were on an inpatient unit, and that is the means of suffocation or asphyxiation, where somebody tries to cut off the oxygen supply to their brain, either by hanging themselves or otherwise strangling themselves. And this was something that was often talked about on inpatient units, but I did not see talked about as often in outpatient settings or when doing safety planning. And yet, if we look at the data, for 2024, for all of the US, the methods of suicide that males of all ages died by, firearms consist of 66%, and yet suffocation is a quarter. I mean, that is still a very significant percentage, and I think something that doesn't receive the attention that it warrants. I see us spending a lot of time about, securing pills, making sure all blades are locked up, but we look at those means of death by suicide, and they are significantly lower compared to suffocation. I think it's also important for us to, look at the data in an even more narrow form, particularly for young people that may not have as ready access to firearms. And so if we look at males from 10 to 17, while the rate of firearm deaths stays roughly the same, the rate of suffocation deaths increases to a third. Right. And so, particularly for those of us working in pediatric spaces, working with adolescents, I think it's very important for us to consider suffocation when we are talking about means restriction. I think it's also interesting to note that poisoning, which is defined as overdosing on medication or other drugs, constitutes only 1%, and there are actually no recorded deaths by cutting. I don't know if that is a reporting error in terms of that, or if that is true, but regardless, much smaller compared to suffocation. Getting even more narrow and even more specific, I think it's important for us to take into consider local aspects of what is going on. And so I reached out to the Pierce County Medical Examiner's office. They were very generous in providing me very detailed information about suicide deaths from the years of 2021 to 2025. And so this is a chart showing the deaths by suicide in Pierce County for 11 to 18-year-olds between the years of 2021 and 2025. And unfortunately, we had 35 youth die by suicide. And as we see here, roughly consistent with national trends, 74% of those were cis male, 17% were cis female, and then 3 were trans male. And this is something that I want to call out, is that I am very grateful for the Pierce County Medical Examiner's office collecting data on transgender deaths. This is something that is not collected at the national level and is a significant deficit because a rate of 9% is extremely disproportionate in terms of the population size. And so I am grateful for the Pierce County for making their best effort to collect that data, as that can also inform what we do in policy and clinical settings. And so if we look at means of suicide in Pierce County for 11 to 18-year-olds from the years of 2021 and 2025, we actually see something very different compared to national trends. And so I am always grateful for the folks of Kids Mental Health Pierce County, as we're always trying to take a local lens to what we're doing. And, so it's very unfortunate to see that nearly 60% of those deaths were by means of suffocation. Why is that? Perhaps we have, better firearm restrictions here, better securing of means, maybe less access. I don't know, but I think this is an important trend for us to pay attention to in our local area. So, some things that we could take action on in regards to means restriction. So one, as policymakers, we could consider supporting anti-ligature initiatives. As institutional leaders, we could make sure that, do our safety plan templates include securing ligature risks and talking about that? This is something that we could do with parents in the emergency department. This is something that I have implemented in our IOP that we talk about and is included on our safety plans. I think one of the reasons why this may be challenging is because there are potentially so many things that somebody could use, but reducing access, immediate impulsive access, is very important, and oftentimes something that can be done in a small window of time when somebody is considered to be at acute risk. And then another thing we can do as clinicians is asking about these risks in homes and discussing risk prevention. So another thing that I want to talk about in terms of suicide prevention is who goes unseen? Who are we not capturing in our research, in our interventions? And in our clinical settings. Because despite all of our efforts, and so many people have been putting in efforts for decades, we are still seeing increased rates of suicide. Again, not only for men, but also for women as well. And so there was a paper recently in the Journal of American Academy of Child and Adolescent Psychiatry talking about different groups of youth that they identified between the ages of 10 to 17 who died by suicide by 2013, 2022. Now, I will make more sense of this slide because there's a lot of information, but essentially there are the groups that were known to have mental health concerns. So 12% had been identified. These were predominantly female who had died by asphyxia or poisoning. There were 13% where there had been previous disclosures of suicide intent. For example, there was a history of attempts. Perhaps they were actively in treatment. And then we have these other groups where 25% of this cohort, they died by suicide after a crisis when they had had no prior care. And then there's another group of approximately 20% that were hidden, where there were no recorded risks, no history. And this group was predominantly male and firearms. And unfortunately, I have talked with local leaders and people that work in the healthcare system, and they have shared with me about youth that they know that have died by suicide who fall in this category where no one saw it coming. And it was very surprising to everybody. And then the last group that I identified is where, when looking at the data in terms of the suicide death, there were documentation gaps. There really was no information known. And I think this data can really point us to maybe some ways in which we can change our approach to suicide prevention. And so the way that I kind of broke those groups down was that really approximately 50% of those are kids that we have no prior knowledge of, that they are at risk of suicide. About a quarter are kids that have been identified. These are the kids that are in clinics, perhaps have got an emergency room, have had multiple inpatient admissions. So that's only about 25% that are really making contact that we know of with the behavioral health system. And then there's approximately 30% where there is major gaps in the data. Perhaps they tried to do psychological autopsies or they weren't even able to do that. So data was missing, right? And I think this represents a big area in which we could change our approach. This is also suggesting that, perhaps current prevention efforts such as healthcare screenings, lethal means restriction may not be reaching or effective for everyone. And so one of the ways that I was thinking about this, thinking about, okay, if we have, at least roughly 50% of youth dying by suicide that we were not aware of, right? These are the kids that we're saying, I never knew, I wasn't aware. How do we rethink what we consider a behavioral health space, and how do we create more connections in our community, right? We've already identified, for example, that loneliness is one of the contributing factors to suicide. And so I just want to share some local examples that I think are doing good work. So for example, like innovative change makers, cultivating community for young people. I also want to highlight Game Time and their impact nights, creating community and creating a village for youth and the people that are involved in their care. This goal of breaking down the barriers between home, school, and community. One of the things that we have seen contributing to the increase in loneliness is the loss of third spaces, right? The spaces where people gather outside of work, home, or school. And so, for these kids that we're not identifying, perhaps one of the way is increasing these connections in these other spaces. And perhaps we can even think of these things not only as, social interventions, but as behavioral health interventions as well. And so some things that we could think of that, again, we could take action on, as policymakers, we could consider research into the hidden and crisis populations that die by suicide without warning signs. Also, that 30% gap in information that we have. Perhaps if in your local area there are no psychological autopsies, which is when somebody dies by suicide, experts will do interviews and do retroactive investigation of what may have led to that suicide. So support for psychological autopsies, and then also considering additional funding for these non-traditional behavioral health spaces that I've described and shared. As institutional leaders, we can also do more analysis of the populations that we serve, and are there gaps in terms of demographics, ages, genders, and ethnicities? Is who we're serving, does that reflect the community that we're located in? And then as clinicians, we can consider alternative service delivery. Could we consider more in terms of outreach and things like that? And I know locally in Pierce County, there's a lot of good outreach that is being done in schools and communities, and yet we know that there is a need for more of that. So I want to transition to talk specifically about male depression. You've learned fairly sobering facts about male suicide and perhaps some things that we could do differently to approach that. And I think one of the steps in that is also rethinking how male depression is conceptualized and how it is diagnosed. And so if you're like me, if you did mental health training, you may have learned some sort of mnemonic, that helps you remember the diagnostic categories for major depressive disorder in the DSM-5. The one that I learned was SIGI CAPS, looking at changes in sleep, interest, skill, energy, concentration, appetite, psychomotor, disturbances, and suicidal ideation. And yet what we have found is by using this criteria, it may not be capturing depression as it presents in men. And so according to the Anxiety and Depression Association of America, nearly 1 in 10 men experience depression or anxiety, but less than half receive treatment. This may even be an underestimate if we're only using traditional means and traditional criteria for diagnosing depression. And so there has been some, what I think, really good research in terms of thinking how depression may present differently in men, right? there can be different categories in terms of how their emotions are expressed, their behaviors, and things like that. And so this is a proposed scale or screening tool, which has a lot. This would be a lot, unless I'm giving somebody like a sheet of paper to kind of check things off. Unfortunately, I know a lot of us in the mental health space aren't necessarily, you know, given a ton of time to be able to go over so many questions. And so what I did was I looked at how this male-specific depression screening tool sort of broke down into categories and created my own acronym, because why not? And I actually think it, for me at least, well, probably because I created it, it's kind of an easy acronym for me to remember, but the acronym of ERASES. And one of the things that I think about is that, you know, depression erases your loved one, right? And it changes who they are at baseline. And so these are the broad categories that may be more predominantly presenting in men compared to women. And so one of the things is emotional suppression, right? So, and as opposed to necessarily being sad, dysphoric, tearful, there's actually a numbness that comes with it, right? And that, you know, this idea of I just need to push everything down and then I will be okay. There can be increase in risk-taking behaviors, right? Yeah, aggressive driving. Perhaps they, you know, are more impulsive. You know, maybe they are gambling more and things like that. Uh, Another aspect is anger, right? That oftentimes we think of anger as a response to either other emotions, life events, or things like that. But oftentimes men will say, you know, like I have such a short fuse, right? Anything will set me off. Like, and so you see these increased bursts of like anger and aggression. Um, Unfortunately, men will also try to self-medicate with substance use, with alcohol, marijuana, and other drugs. There can also be this type of escapism of, well, if I can't fix my problem, I will just avoid it, right? And escapism can look like something like overworking, right? They pour themselves into the work, or they pour themselves into going to the gym, or something else, or some activity. And almost the idea of if they can be absorbed in that activity, they can sort of disappear and their problems can disappear as well. And then also there can be an increase in somatic symptoms, right? Complaints of headaches, chronic pain, stomach aches, things like that, right? And while I want to say that while these characteristics may be more prominent in men, in my clinical experience, these are not isolated just to men. I actually think that these are characteristics of depression that can go under-recognized for all people, as I have worked with many girls and women that struggle with all of these behaviors too, that appear to be a reflection of their depression. And I just want to call out anger in particular, I think is something that oftentimes we don't pay enough attention to for both genders. So I also want to consider how depression may overlap with other disorders and how that may lead to potential misdiagnosis, particularly in certain populations. So one of the things that I always emphasize with my students that I work with is that, you know, symptoms are not diagnoses, right? Symptoms lead us to a differential of possible diagnoses. And we also don't want to just be looking at one slice of time. We want to look at things over time as well, right? And so just because somebody, for example, checks all the boxes for a certain diagnosis, we need to consider, well, how do those symptoms present as a Venn diagram with other diagnoses? And instead of just looking at the symptoms, what is the etiology? What is the origin of those symptoms? Where are those symptoms coming from, right? And so one of the diagnoses that I want to highlight that has some overlap with this more masculine presentation of depression is oppositional defiant disorder, which we see getting diagnosed at increased rates among boys and young men. And so, for example, we see here, right, anger as part of this, irritable mood, right, argumentative, being spiteful, right? So if we were just to look at this diagnosis in isolation and just checking symptom check boxes, we might go, oh, okay, well, they've got the symptoms, they meet the criteria, so they have this diagnosis. And yet what we need to do is take a step back and consider, well, what else could be causing it? What is underlying these things? And so, for example, I think that this is in part why we see disproportionate diagnoses in different populations. So there was this very large study done recently in 2024 that looked at a cohort of almost 1 million people with ADHD and conduct disorder. So ADHD, as we know, attention deficit hyperactivity disorder, and then conduct disorders include things like conduct disorder, where people are hurting other people, being aggressive, breaking the law, but it also includes oppositional defiant disorder. And what they found in this study is that white individuals were about 26% more likely to receive an ADHD diagnosis and 61% less likely to be diagnosed with a conduct disorder than Black individuals. And I am wondering, one of my hypotheses is, are we missing a lot of what is underlying these symptoms for Black and brown boys, right? That is leading to these disproportionate diagnoses. And are we missing depression or other things that are going on that they are expressing differently, or that is being interpreted differently by clinicians? And so with that in mind, I want to highlight another organization that is doing good work in Pierce County, which is Black Boy Heal, which provides mental health services for any male identifying Black individual and providing culturally sensitive care, which I think is a really great initiative that is happening in our local community. And so some things in which we can rethink depression and how depression presents for males. As policymakers, we could think of perhaps male-specific mental health advertising that helps reduce the stigma around depression and providing information about how it may present differently in men. One area where I see a large gap in terms of mental health interventions and services is for justice-involved youth. Unfortunately, I see many justice-involved youth falling through the cracks where they are considered too violent or aggressive or a danger to others in behavioral health spaces. And so they are often excluded from those spaces, which I will be honest, I think many people in those spaces would like to provide that service, yet understandably have safety concerns and have limited staffing support areas where they can be safe to provide that care. And so by no means am I blaming people in behavioral health spaces, right? I exist in that space. And at the same time, what I see is that youth are in justice-involved spaces. There is a focus on incarceration and perhaps not as much focus on treatment, and it can be limited. Now, I am not in that space, and so I am not going to speak definitively about that, and I'm not going to make any judgments about that space, right? But that is what I'm hearing from when I have talked to people related to those spaces or youth that have been involved in those spaces. And I am wondering if there is a way that we could bring the Venn diagram of those two spaces closer together and overlap more to serve this population that is really falling through the cracks. Another thing that we could consider is, as I shared, considering something as institutional leaders, implementing gender-specific depression screeners. And I would also say, I think screening for these things, as I outlined in ERACES, is actually something I'm doing for people of all genders, as I think many of those symptoms go undiagnosed or unrecognized in female patients as well. So I want to take some opportunities. So we've talked about, two major concerns in terms of male mental health, the crisis of suicide and how it is increasing, particularly among young men and the challenges that they face. We've talked about just one diagnosis, depression, and how we could think about that differently. And I also want to take this time to share with you all resources that may be helpful as you are looking for more information. So one of the things that I am honored to have been a part of is recently Pierce County Executive Mello increased investment of $300,000 to expand biometric gun lockbox distribution within Pierce County. As we saw in the data, death by firearms among suicide is one of the leading causes for all people. Also in terms of homicide deaths as well. And so I was honored to support this initiative. These are gun lock boxes that are going to be available and free at community centers and are biometric, which means that they utilize fingerprints to respond to. And so I think these sort of very specific targeted interventions can be very, very helpful. Some other resources, so looking at online resources that I think are very good. I have referenced some of the data from the American Institute for Boys and Men. It is led by Richard Reeves. And what I like about them is they really, they dig into the data sets from the CDC. They do their own research. They also support a variety of evidence-based interventions. And I highly recommend this book that he wrote of Boys and Men, really looking at why the modern male can be struggling, why it matters, and also some possible suggestions for how to intervene and how to support. And so I highly recommend this website. And Richard Reeves has a TED Talk, and he's often interviewed. And I think he just takes a really great balanced approach to this issue. Other websites that are helpful, headsupguys.org is focused on mental health for boys and men. This is also a website that goes into more male aspects of depression, has a lot of really good articles and stories, and as I was going through it, has some pretty good information on there, and also has links for finding therapists that specialize in providing behavioral health services for men. Movember, everybody may have heard of Movember happening in November, but this is when many men will shave and then grow a mustache in recognition of male health issues. So this isn't just mental health issues, but all issues for men, but they do have a particular area of focus on mental health as part of the work that they do. And I think they've got some pretty good information. One of the things that I talked about earlier, was sort of this, masculine bias towards action, maybe perhaps responding to men in non-traditional therapy ways, where maybe it's not directly about, okay, we're gonna sit down and talk and do therapy, but like, let's build community and do things together. And while my focus of this presentation has been primarily on young men, this is a resource primarily for older men, because as we saw in the age information that I shared, older men are significantly affected by suicide. Um, Part of that is, the idea of like after retirement, particularly men who are widowers lose their social connections. It's known that men do not build social connections typically as well as women and lose that support, which my understanding is one of the contributing factors to increase suicide in older men, as well as just sort of this overall loss of a sense of purpose. And so this is an organization called Men Sheds, which I think are really cool, of bringing men together in activity spaces where they build things, they do woodworking, they do a variety of activities, and it's actually pretty cool. They have a lot of intergenerational stuff as well for young people and older people. Um, they also have a partner effort, women's sheds as well. And so, I think just having the intergenerational cross-gender efforts is great. And this is also something that young men could be involved in as well. And so I also want to acknowledge the limits of my current presentation. I wanted to take the opportunity to talk about, broad topics and then diving deep on a couple of things, right? Talking about, the increasing rate of suicide among young men, particular demographics of young men, I think is something very important that we need to be paying attention to. I wanted to call attention to the risk of suffocation and ligature as a means of suicide. I think addressing that is something that can help us reduce rates. I wanted to talk about, the specifics of a single diagnosis, to kind of dive deep, and how that particular diagnosis of depression could potentially be misdiagnosed. However, this really is just the tip of the iceberg of this conversation. And there are so many other topics that I would have loved to have gone into, but unfortunately, with the limitations of time, not able to do that. But things is, further conversation about masculinity. And what does that mean? How is that defined culturally? And how is that defined individually, right? And who are we limiting aspects of masculinity to? And who does that apply to? I think there's a lot there. And what does a robust, healthy masculinity looks like for somebody, and a masculinity that supports somebody's mental health? And like I said, I think part of that is that reorienting of what masculine ideals look like in terms of, if I support myself, I can support others, I can provide for people, I can protect the people that I want to, I can accomplish the things that I want to, as opposed to this idea of I need to be isolated and alone and do everything by myself. Oftentimes that leads to more limitations for somebody. So how do we create something that's more robust? The opioid crisis is something that is very, very significant, disproportionately affecting men. The rates of death by opioids, particularly fentanyl and other synthetic opioids, are even higher compared to suicide. This also is something that disproportionately affects men at a rate of about 2 to 1. It also disproportionately affects Black communities, and this is something that is also currently a crisis that is something that we need to address. Other things that tend to come up more for men include difficulties with gambling, particularly with the proliferation of online gambling and apps for gambling, sports betting, things like that. There has been an increase in those issues. Different forms of internet addiction, gaming addiction can be very, very challenging. There's a lot more to say about the economic challenges and how that affects the mental health of boys and men. Educational challenges. We now see that the majority of people being enrolled in colleges are women as opposed to men. As we talked about, that There's also challenges in providing technical school education, and yet we're going to need more and more of that in this world, as there is a very large deficit, growing deficit in terms of people that are skilled in the trades. Talking about online spaces, the spaces that people gather in online and communicate with, there's a lot of misinformation, a lot of very, very negative misinformation that is tapping into a lot of people's concerns and anxieties and directing them towards solutions that just are not going to help them and honestly are not evidence-based or fact-driven. Further discussion is needed about violence and the significant rate of homicide among boys and men. This has been an issue that we've been trying to address locally. And then also the issue of incarcerated and justice-involved youth and that gap that I mentioned of how can we bring the Venn diagram of behavioral health and the justice system closer together to provide services for these youth. So there are a lot of other topics. If there's interest for that, I've already talked with Ashley and Vanessa of perhaps we could have other speakers, perhaps panels, things like that. I think would be really great. Another thing is I want to draw everybody's attention to Pierce County is having their first annual Suicide Prevention Summit and 5K run. It's this September 18th, 2026. I will be there. I will be co-hosting with a youth, a panel on youth behavioral health and how it relates to suicide and suicide prevention for youth. And so please come join me there along with a variety of other great speakers. I understand they have a really good keynote speaker lined up for this. So please save the date for that. And then I just want to say in terms of other topics, there are many other groups to talk about as well. You know, perhaps it would be great for the next Women's Health Month that we could have a presentation on, you know, rethinking women's mental health as there are a lot of unique issues facing girls and women as well. And so I just really appreciate the opportunity to have this conversation. I welcome any questions. I do apologize as I estimated, we went pretty close to the end here, but very grateful for all of you. Thank you for listening to this presentation. And that is all from me. Thank you.
Thanks, Lucas. Thanks, Dr. McIntyre. So grateful again to have you and just all of your expertise and your heart to support folks here. We are coming close to the end of our time, and I want to invite folks to take a survey, take a quick survey, scan the QR code. I'll also send out a link to this. This was recorded, so I'll send a link out to folks who attended and the survey QR code. I am going to share my information. So if folks do have questions, you could email me directly and I can connect you with Dr. McIntyre. We are excited to have ongoing discussions, like Dr. McIntyre said. Lots of questions that arise from information. So I'm sure that folks' brains are really thinking, and that's how we can continue to cast a wider safety net for specific populations and our broader populations here in Pierce County and around Washington State. So thank you so much for attending. Please take the QR code. And if you have questions, please email them directly to me and I can go ahead and share those. Thank you again for attending. Thank you to Kids Mental Health Pierce County, Marybridge Children's, and Dr. McIntyre.
Thank you, everybody. Thank you, Vanessa.